On behalf of Argonne, I'd like to thank you for coming here today. I think there's a really great program. We're going to talk a little bit about issues with filter and specifically about the option filter. You have three outstanding faculty here, and we're going to get into some very deep detail on the filter itself, on results from a 1,000-patient study, and some different types of techniques that really make this filter unique. It happens to be a filter we use a tremendous amount in our own practice, and we're very happy with it. And I think that if you haven't used it, you'll find that you like it very much when you start using it, and I hope for all those that are using it, you'll realize that it is a great filter. So our first speaker is going to be Matt Johnson. Matt's a professor of radiology and surgery at Indiana University. Matt has extensive experience with this filter, and I'll introduce Matt.
And I am extremely pleased to be able to talk about this because this filter is obviously near and dear to my heart. I've been with it since the beginning. And by that, I mean since the beginning of this filter, and before that we had a lot of discussions as well. But filters themselves, as everybody knows, are decades old. The Greenfield filter being introduced around the time I was in elementary school. And then after that, in 1990, that's true, I was. That's how you, it was. I was just, yeah, so I was there. And then in 1990, the first filter that came out was nitinol. So now we're building on. You see the difference in these filters as we go through. And the next filter was a single hypotube, which is better because it decreased the weld points and is not as likely to break. That was in 2001, I think. And then that was right before the new entry of the retrievable filters, the first one being the Tulip. And then in 2010, we presented our trial of the original option filter itself. So you can see how these filters do not look the same. They are not the same. It truly has been an evolution in everybody trying to make their filters better as we get more data and we understand more what's going on inside the body. And that's true in the option filter itself. This presentation is about the evolution of the option filters to the OptionELITE. Neither of these is that. So I'm going to point on this screen, but this is the original one that we started working on in our sheep. And then because of what I'm about to show you, we changed it. And the reason we changed it is because if you can see this, and I apologize for people looking at that screen, but I'm going to point at both. You can see this strut that went straight out all the way. It was clearly outside the vena cava, clearly penetrating, and it wasn't the only one in this sheep as we were evaluating this. And you can see this was back in 2005. And so we made modifications, and the modifications that we made were to change the feet. And so I'm going to show you the feet now and the things that were done that turned out to be extremely beneficial. There are three different, There are three different things that matter. One is that we extended this. So we've already had that. That's number one, is to have this hook pointing up. But you can see the serrations on the bottom of this, the grippers that you can see, and then an extension to keep it from penetrating. Like I call it a foot pad. They call it I've always called it a foot pad, but I learned today, or a little bit recently, that we should be calling it an extension. Both these filters are single-piece nitinol, so using that methodology, electropolishing, which decreases fracture rate, and we know that, and I don't know why, but the engineers know why. If you smooth it out, the filters are less likely to fracture, and these have been electropolished forever. I also learned something. You might ask, why do you give a talk like this? Why, when you've been doing it for so long? One thing is that I learned stuff from it. And I remember doing the trial and knowing we had discussions with the FDA about and using the 510K process to get the filter approved, and I knew that we couldn't say what I wanted to say because these are clearly filters that we were putting in cavas that were bigger than the standard 28 millimeters. And I had thought until today that what we ended up in that discussion was that the option can be used in cavas up to 28 within FDA guidelines. As it turns out, it is cleared for use in 30 millimeter cavas. So I learned something just from the lecture that I prepared, and that is that, and when you have to go back and check the data that in detail, you realize that sometimes your thoughts are not what you thought they were. And this is actually now you can use this filter in vena cavas up to 30, and that's approved by the FDA. The flared strut pattern was there, and we've seen that. It's better to have conical filters that direct things this way instead of flow, like if you put a filter in like this, the blood flow goes this way. It interferes with laminar flow, and you cause increased rates of thrombus formation because of the change in the flow characteristics through the filters. So these are good filters that direct flow that way and direct clot that way. So that's another thing that you should think about when you ever look at these computer-generated flow models and the actual flow models themselves. And then this is the deployment system. They used to say that it was 6 French, but it's actually 6.5 French out on the outside, but it's still extremely small and extremely to put through using very standard equipment. The curved pusher, this is I've argued with Jim McGuckin since the day that we started talking about this, that he loves the curved pusher. It's like the best thing in the world, and you can feel it. I put it through the neck. I almost always put my filters through the neck. He puts his filters through the groin. I think there may be a benefit if you're doing groin filter placement. I don't know. I don't do that very often. But it doesn't interfere with my placement from the neck. I mean, you get nice centering on this. We showed that in our study. We got follow-up study that shows that it centers quite well. And as I just mentioned, you can put it in from above or below. It's very clearly marked, but do pay attention to which side you put it in because it goes in easily. Just got to make sure you put femoral through femoral and jugular through jugular and snap it in. This is also gratifying to me to have this in this detail, in that the things that we saw in our study of the first 100 patients of this is that all these things you see are very close to the same in the follow-up in the next series. I love to see data being repeated to suggest that what we thought is true is true. And also I liked, the only thing that's substantially different is the occlusion rate, and it's much less in that filter study. And we were being extraordinarily rigorous and reporting things like caval occlusion in people who already had cavas that were filled with clot when I put the filter in. I did one of those caval occlusions as mine, and I put the filter on top of clot. That counted as a caval occlusion, but we needed to do it. That was fair. So I'm pleased to see, as we move on, that the things that I thought were true appear to be true. But that then brings in what's different now. And one of the knocks against the option filter is that it's harder than other filters to take out, than some other filters. Not all. I can go through them in great detail if you'd like. But in my answer to that was you put the filter in, you want it to stay in. You don't want it to move. And it seems to me this is pretty much hitting the sweet spot. But we did studies of this. So here's what's happened. The OptionELITE, I'm going to show you what happened. You can see that the hook looks a little bit different, and that's the important point. But also the feet have been changed, and I think that's important. This is a little cartoon. It's not the world's best cartoon, but you can clearly see that those 3 big hooks have been replaced with little hooks, and that matters. And it matters actually in practice, and it matters in the lab. This, we've already talked about the anchors and the hooks and the grips and that stuff, so I'm not going to go through that again. Same idea. I hope you guys can see this, because these are the data that, and I did a lot of this. So what we did in the top half of this is we took a whole bunch of different filters and we pulled them out of sheep at 1 and 3 months. And you can see that the forces that were used in the option were in the 7s range, 7 foot-pounds in this kind of area, which is a tough thing. You get up to 12 and so it's really hard. So pulling out that, and if people have used this filter, they know it's been kind of tough. Not impossible, it's not that difficult, but it's harder than others. And so what was done then is they modified the feet, and we tried it in, and I didn't do the OptionELITE pulling out of sheep part. I did all the stuff at the top, but I didn't do the bottom part. Some Yahoo did, but it was a talent. Was it you? No, okay. But he was pretty good at it, and the data are straight across. And what you saw in that model, and then subsequently in the in vitro model looking at retention force, which is here, this is an in vitro model of retention force, is that it decreased the need to withdraw. The withdrawal force is much less with the option, but the retention force, meaning does it stay in the cava, stayed about the same. So that was, in my belief, in the animal lab, that was a great modification. And it turned out in the clinical lab that it's worked as well, and I'll show you that. Why does that matter? Well, you can take out filters, and because I do so much with filters, I take out filters that have been in for a long time. The harder the pressure, the more complicated. It's just really hard. And you can look at this one. This is a filter that I've pretty much had to do everything in the world to take out. I'd already straightened the hook up, so I eventually needed to use graspers to pull onto this because I made the hook straight. And I lost it in the cava, so I had to grasp it from below. It had a penetrated little tiny foot here. This is not an option. But it had been in for years. It had been in for years and had penetrated everything, and we needed to take it out. It was causing pain. But eventually, this is a laser. So I had used a laser, I'd used graspers, I'd used this. It'd be nice if you didn't have to do that. I mean, if it did its job, didn't penetrate, could take it out when you wanted to. So I at this time didn't know whether this was an option or an OptionELITE, but it was a filter I thought was appropriately taken out. We'd put it in a year ago, prior to a guy getting a liver transplant and he had clot at the time, he needed it. So then he came back, he's asymptomatic, has had his transplant, no longer even needs it because he's anticoagulated. So we look through when do you take out a filter. I'm not going to go in for length about all this. I've given this talk with this case before. The cavogram took place at 252. The snare was out and snared in 8 minutes. And that's a year-old option. So it's not like it's impossible, but to make it even easier without that need is pretty impressive. And so we were one of the centers that evaluated the first ELITE, and I didn't put in a lot of them, and I didn't take out a lot of them, but it was obviously easier to take them out. And now that it's out and available in practice, it is clearly easier. And I'm going to give it to Dave Trost from Cornell, and he'll talk about his study, and then we'll move on to talking about the over-the-wire technique.
I'll just comment on it now. I'm going to show a study. It's a retrospective study that we started back when we first got the option filter. It was July of 2009. They had the first pre-market release. And I started collecting. He said, okay, I'm going to look at some point I said, I'm going to look at every patient that got an option filter up until a particular time. Basically, it was the time I could get it ready for the SIR meeting for an interim, some interim numbers. And I'll show you the results to that, and we're going to continue doing this to have a total of 1,000 patients, but I'm going to show you almost 400 here. Here are my disclosures, and so this is our initial results with the option, and we're going to continue to review and put about another 600, 650. I don't know the exact numbers yet because we have to pull them out of our database, but it's going to be a little bit over 1,000 filters and 300 retrievals, and that will be a mix of the option and OptionELITE. This current data is only for the option. Between July 2009 and September 2011, we looked at 371 consecutive patients that had the option vena cava filter, and we retrospectively reviewed this under an IRB protocol. All the placements were using the standard techniques that came with the filter, the standard sheets. The filter retrievals were initially tried all with the standard retrieval techniques, but there were some additional retrieval techniques which I'll mention as we go on that we needed to use to get some of these devices out. 371 patients, 200 males, 170 females, averaged around 66 years old. You'll see there was a broad range. There was actually a 12-year-old in there, and you'd say, why does a 12-year-old need a filter? Well, this kid with a brain tumor and DVT and PE actually did need a filter. These were the indications. And as you can see, we do place quite a few for prophylactic reasons, but we have a pretty good distribution. A lot of them were DVT or PE with contraindication to anticoagulation. So we had 375 filters in 371 patients. Now, how does that work out? How do you have more of that? Well, 2 patients had a duplicated inferior vena cava, so they each received 2 filters. Well, one filter didn't open due to, and this is a weird one, it says a fibrin band, and actually one of my partners did this case, and there was looked like a wedding band, rubber band on the bottom of this filter, which we did take out because it didn't open, and it went to pathology, and they just said it was acute fibrin. I don't know much about it, never seen it before, never seen it since, but we'd replaced that filter, and of course, we had, somewhere that cartridge, you got to make sure you use the femoral and jugular correctly because we had one that was placed inverted. All those filters were immediately removed and replaced with a new device, and I don't count that as a retrieval in our longer-term retrieval data. We also had one that was deployed into thrombus that was repositioned. So we didn't count any of those. So a total of 373 cavas were enrolled. So those double filters counted as 2 cavas. Here was our median and mean cava size, right around 20 millimeters, with a plus or standard deviation of about 4 millimeters. The filter tilt on placement, it was pretty straight on most of these. And negative is to the right, plus is to the left. They all tilted a little bit to the right, but not very far on average. But there were a couple, a broad range, up to 20 millimeters, 20 degrees on a couple of them. But overall, they were pretty straight. We are also a jugular placement house. You can see 355 of the 358 were placed via the jugular vein, either the right or the left. Very few femorals. So, and I also agree with Matt. The curved pusher doesn't do a lot for me, but we're going to hear more later about how to keep these nice and straight when you're placing them from the groin. Our retrieval population happened to be completely by accident, exactly 100 patients, pretty evenly distributed male, female, again, right around 60 years, 64 years, and a range of 12 to 86. And here's the indications for the people that had retrievals. And thankfully, most of the retrievals were in that prophylactic category. So of the 100 retrievals, we had one patient that presented on initial venocavegram, had thrombus in the cone, and the decision with the clinician was that will remain a permanent filter, so that sort of fell out of our retrieval data. 99 patients we had retrievals attempted. Of that, we got 97 out. And you'll see an asterisk there. And the reason there's an asterisk there is one of those patients was a very straight filter, very easy to grab, very easy to oversheath, but it was very early in the experience, especially of one of my partners who said, I'm not going to pull quite that hard. I can guarantee today that filter would have come right out. But it didn't come out, so I have to count it as a retrieval failure. So here is our implant time, median to 74 days, mean was 96 days, and the longest we had between 7. The longest retrieval we had was 474 days, and that actually turned out to be one of the easiest ones. Most of them were taken out using the standard snare and sheath technique, 88 of the 97, and we used what I call a tip deflecting wire technique. For those of you that were at Dr. Rayu's talks, it's basically a technique to try to break these tissue bands that hold the tip of the filter against the wall, and if we have time, I'll show you what that means. Looping a wire under the filter, sort of the standard techniques that Wilquo or loop snare, to try to get them down and oversheath a tip that is embedded in the wall. These are the failed retrieval attempts. Patient 1, this is the one that was a real retrieval attempt. This filter is tilted. You can see 21 degrees. Penetrated. It's penetrated 7 millimeters. It's by far the longest penetration we had. And it was tried 3 times, once by one of my partners and twice by me. And ultimately, after in this 74-year-old who was completely asymptomatic, who actually had many other comorbidities, we just said, we're leaving this. I'm not going to go crazy. I don't have to get it out. The second patient, that's the one that I'm sure would have come out today. It was a very short procedure. It was not tilted, and I'm sure that we just did not pull hard enough. Migration basically I looked only on our retrieval patients because a lot of our other follow-up patients didn't really have good imaging to try to figure this, but we had cavograms that I could truly match from the placement to the retrieval, and we had no migrations, with the definition of migration being anything greater than 2 centimeters. We didn't have anything that was greater than 9 millimeters, so that was great. No fractures, and I know I haven't seen as I said, I haven't done our follow-up on our 1,000 patients. I know that we have not seen a single fracture in an option filter on probably 300 retrievals. So caval penetration. Now this is an interesting category to look at because it starts with what's the definition of caval penetration. It dates back to a paper by Ernie Ferris from Little Rock, Arkansas, back in the dark ages. I think it was around 1993. And it came out, the definition was 3 millimeters outside of the flow column of the cava. I don't know where that number came from. Maybe you do, but I've never figured out exactly where it came from before that. By strict criteria, I looked at this and said from the cable wall to the tip of the longest hook on the option filter, in 11 of those patients, it was outside the 3 millimeter range. In 6 of those patients, it was outside the 4 millimeter range. And every patient was asymptomatic, and frankly, I don't think this means much. I mean, true penetration may mean something, but these 3 millimeters, for any of these filters, I don't really think means much. Fluoroscopy time, well, average retrieval time was pretty short. The total time of 9 minutes was, mean and median were 5 and 9 minutes. Our shortest retrieval was 1.2 minutes of total fluoro time, so very, very short. And you can see of the patients that we did not retrieve, those were the fluoro times of the patient 1 that had the tilted filter we tried 3 times, and the patient 2 that we should have pulled harder. So whether our follow-up of our non-retrieved patients, median was 40 days, mean was 150 days, and the only thing we saw in our long data was 1 recurrent PE, and that was out of 274 filters. Admittedly, it's a retrospective study. The follow-up is not as stringent as you'd like to see. So follow-up of the retrieval patients, On average, we usually show those patients, looked at those patients 1 day later, and we don't have a lot of follow-up after the retrieval. But during their implantation time, we did have one iliocaval thrombosis, which was lysed, and the filter was removed. That's one of our successful retrievals. And I put down the penetrations were 11%, everyone asymptomatic. So what are our study limitations? It's the usual retrospective problems. It's a retrospective study, single center, very limited follow-up with clinical and imaging. But I hope when we expand this to another 600 patients, we will get some longer follow-up. We'll see some more imaging that's sort of accidental, but we'll have it. And I'm interested to see if there's any true differences that we can detect between the Option and the OptionELITE. Matt talked about that there was a pre-market evaluation where a bunch of us got to place some of the OptionELITEs before it went out to general release. And I actually did place quite a few of them, and I had, I think, the most retrievals in the group. And I can say, anecdotally, I didn't have a strain gauge on it. They're certainly easier to pull. And again, I said, I don't have the exact data yet, but I have not seen any migrations. So, conclusions that I had: the option filter can be safely placed and retrieved. In our experience, it's demonstrated excellent clinical performance, minimal complications, and a high rate of retrieval success. This is one of the things that I just want to touch on. That one of the things I think is very important is if you want successful retrieval, you should think about it when you're placing the device. There are things you can do to try to make sure that your retrieval is going to be a success. One of them, this seems dumb, but make sure the access needed for the retrieval exists. If you're people that put them in, if you always put them in by the femoral approach, once in a blue moon, these patients may not have upper jugular or upper extremity access to get these things out. I've had that happen. I also had a patient that had a left-sided superior vena cava. Do I really want to do my retrieval through the coronary sinus? Didn't necessarily want to do that, so I put an Optese in that patient. That's the only Optese I've ever placed. Orient the hook so it's easier to see in the AP view. You can see it through the sheath, and sometimes you can twist the sheath and get it so that it's going to be very easy to see when you go to take this thing out. And I try not to place the hook of the filter exactly at the renal vein, so if the filter tilts, now the hook's way out into a renal vein. I'd rather have it above the vein. I'd rather have it below the vein. I just think it makes it easier to get out if it has tilted. And try to keep it centered in the cava if possible. And that's sort of going to lead us nicely into the next talk here, talking about over-the-wire placements and what techniques we can use to try to keep these things better centered. So thank you for your attention. The next speaker is going to be is Dr. Nazzal. He's a vascular surgeon from University of Toledo, and he's going to talk to us about over-the-wire placement, which is something that has been recently approved by the FDA.
Well, thank you very much for all of you for being here. I think my job is the more exciting job here, which is to talk about the new technology, which is over-the-wire insertion. Again, my talk will start by not telling you, should you use a filter or not. You reach the stage that you are using this filter, and the next stage is, if you are using a filter, why it should be over-the-wire filter. The OptionELITE filter was recently actually approved as an over-the-wire. That was in December 2013. And with this, it will be the only filter that has a retrievable, the only retrievable filter that has the over-the-wire advantage. Why over-the-wire? We all do endovascular interventions, and we all say that if the wire is there, you are safe. If the wire comes out, you are not safe. The same principle apply here. So that will give you more routes for insertion because you can stabilize the delivery system. It helps you manipulate the filter to a central position, and I will show you a picture how to do that. And also can manipulate the position of the filter when you retrieve it. We have many cases in which we are able to go through actually the middle aperture of the filter in order to retrieve a difficult filter. Symmetry and over-the-wire is not something new for filters, and this was tried by Greenfield Filter many years ago. They compared it to the one that is not for over-the-wire, and still there is some asymmetry. There is still some tilting with their experience, and I'm not sure actually how we can define tilting and asymmetry in a 2D images, but these are their figures. Out of our experience, though, over the years, I'm sure it is your experience the same, in order to retrieve a filter, you have to have it in a central position, the easiest way to do it. it might not make a difference for capturing the clot, the filter is tilted or not, in my opinion, but it will make a huge difference in order to retrieve that wire. That is why over-the-wire insertion for a retrievable filter is very important. Central tip location is important, and I will show you some pictures about that. In a recent study from University of Pittsburgh, Dr. Macaron group, they looked at all the filters they inserted, about 471 filters, none of them option actually. This is an older study. And the older collection of data, and they found there's about 4.2% actually technical failure, 4.2% thrombus, so the filter was not removed. But among the ones that were removed, the challenging filters, they had tilt-odd ratio for being unable to remove this filter easily was the tilt, the odd ratio was 2.6, and also the filter opposition to the wall about 6.1. Both the option and the OptionELITE filter were not marked as over the wire, but that's why I'm talking here. I always use them over the wire, especially in difficult cases. And our experience with over the wire, because you can adopt and adapt that filter over the wire, goes back to 4 years. The presence of a filter separate from the delivery device is very important. So that separate cartridge allowed us to use the filter in many ways, and I'll show you some of those. Let's talk about actually the crux of this talk, which is how to do it over the wire using the femoral approach, which is the one I use a lot. You need a wire, of course. I prefer the J-wire, but many people actually use any angled wire. It should be a little bit stiff wire than the glide soft wire. When you do it over a J-wire, you have to be careful when you pull the J out, not to pull the wire with it. So you have to stabilize the filter, as I will show you before you pull it out. Then you can use the dilator of the sheath, the delivery sheath, as a pusher rather than the angled pusher that Dr. Johnson talked about. And you have to stabilize the filter very well before you pull it out. Access the groin like anybody else. And then through the 6-French sheath, which has nothing to do with actually the device itself, any 6-French sheath, you can do a venogram, then insert the wire. I use a J-wire. And the next step is to introduce the delivery system over the wire, and then introduce the cartridge over the wire. You can do that 2 ways, either from the back end of the wire, which is the stiffer end, the straighter end. This way, you know you will go straight through it, but make sure you are going to put your finger on the other end so you don't push wire out. Or you can go through the angle one, but again, put your finger on so you don't push the wire out, the filter out. And this is now the dilator, as you can see it here, coming in behind the filter in order to push the filter inside the sheath. And as you can see it, now it's over the wire and it will be released. Before you pull your filter out, you need to do this step on the right, which is very important. You push your delivery system, the same delivery system, with the dilator, straighten the wire very well, and pull your guide wire out. If you need to give a stronger push for the wire to make it central, you can, but most of the time you don't need to do that. But this stabilizing step is very important. And then you remove actually after that your delivery sheath. But now we use it because it's over the wire to do other methods. And other methods like using the IVUS, I will go through this very quick. After you do your IVUS, decide now how long the delivery sheath should be in the patient's body based on your ultrasound. As you can see it, you measure it here. Then you deploy the filter and introduce your catheter for the IVUS again, looking for the delivery to make sure it is in a good position. And you can see here actually the tip of the wire is central in the center of the IVC. Another picture from another patient, and you can see again the tip of the filter is in the middle of the IVC. In the future, that will make it easier to retrieve. We did about 126. I'm not going through that data a lot, other than 126 over the wire. No, sorry, 126 delivery using the IVUS. Some of them are over the wire. So in conclusion, the OptionELITE filter is the only retrievable filter approved for over-the-wire insertion. And over-the-wire insertion, like any endovascular procedure, expected to ensure central location of the filter tip, allows more entry sites for insertion and easier IVAS-guided insertion, because actually it cut one step less when you use the IVAS, and it potentially allows easier retrieval of the filter.